So, good morning, everybody. So, this is the third time we do a live surgery in collaboration with Medtronic. Today, we will present you a case of a female patient of 56 years old. She already has a long history of chronic sinusitis with nasal polyposis. She told us that in the 70s and in the 80s she had multiple sinus surgeries. Probably this will have been polypectomies. And one of these surgeries was complicated by a methicillin resistant Staph aureus infection, where she had to be hospitalized for IV antibiotics. We did some workout like we in most cases do. So we looked for allergies. So she was skin prick test negative. She is a patient with concomitant asthma and with aspirin intolerance. At the time of the consultation, she had quite a low blood eosinophilia with 3.6%. And both ANCAS and ANF were, let's say, atypical, so we don't consider them to be really positive. She has quite a low total IgE, and we also looked for immune deficiency, so she had, let's say, normal IgG subclasses, and we also looked at the complement and the menin-binding lectin pathway, which were all normal. So for symptoms, she has many years of bilateral nasal obstruction, also with a frontal pressure, postnasal drip, and the patient is totally anosmic. So she also received some oral steroids by previous ENT doctors, but also with systemic steroids, she didn't recover her smell. She has a SNOT-22 score of 43 preoperatively, and what we see on nasal endoscopy, and probably we also see it when we look in the nose, is a quite a big septal swelling on both sides, extending into the olfactory fossa, and also grade 2 polyposis. So we probably think that this patient will have a chronic sinusitis with polyposis, and maybe also a RIA, which is a respiratory epithelial adenomatoid hamartoma, which sometimes is let's say, an inflammation of the mucosa of the olfactory cleft and septum, which can be associated with polyps. The CT scan, we will switch to the navigation for that. Okay, so we will start with the coronal images. So what we see, do you see the mouse? Yeah, okay. So we see here this quite prominent septal swellum. We also have the impression that there are big polyps in the nose. We see some osteitis of the septum. It's quite a thick nasal septum, so this will be, I think, a lot of drilling when we do the DRAFIII. If we go more posteriorly, she has a, let's say, a pneumatized and aerated frontal sinus on the left side and a completely opacified frontal sinus on the right side. We see that the frontal posterior diameter of the frontal recess on the left side is not that big. If we go to the other side, you will also see that there the diameter anterior posteriorly is a little bit larger. And for the rest, we see that the ethmoid sinus cavities are completely filled with probably polyps. Here, I will go put this line a little bit higher. We see that the anterior ethmoidal artery is still in the bone. And if we look posterior, you see that the maxillary sinus have been opened, but are also filled. We see that there is also some osteitis or osteoneogenesis of the maxillary sinus. And if we go posteriorly, we see that the sphenoid sinus is quite okay. So you see that there is a circumferential mucosal swelling on the right side, but on the left side you see that here you have the opening that the previous surgeons did, which is quite well ventilated. So here also you see on the actual images, probably the nose will be full with polyps. So we will start first with removing all the polyps, opening the ethmoid sinus. And Then we will continue with a DRAFIII. Okay. So what are the goals of sinus surgery, especially in polyps, is, let's say, first of all, removal of all the polyps and of all the mucosal inflammation. We call this procedure in Ghent a reboot procedure, where we do a complete FESS surgery, and where we want to obtain a single sinus cavity. And the reason for that is, of course, removal of the disease, but also get good access for topical therapies. We prepared the patient when she walked into the operation theater with a pantocaine adrenaline spray, and then when she was asleep, we put cocaine pledges with 200 milligram of cocaine combined with adrenaline and saline. We call this the Moffitt solution. And perioperatively, we will use 1 in 2,000 adrenaline pledges. We add methylene blue to be sure that we don't mix up any local anesthesia with high doses of adrenaline. So what we will use, we will do the procedure almost completely with a 30-degree endoscope. This is our, let's say, scope we use most of the time. We use a 4K HD tower. We will use a shaver blade, which will be navigated, and also a 30K 70-degree diamond tapered burr. And for instructional reasons, we will also use the fusion navigation. So after the surgery, I think the story continues. So it's not only the surgery. I think the postoperative care is as important as the surgery. We will put our patients with this kind of severe polyposis and severe inflammatory disease on nasal douchings 4 times a day, and we add 2 milligrams of mometasone in these nasal douches. Afterwards, the patient uses ointment. This is the local care. And we also give a systemic treatment with doxycycline for 6 weeks. We will publish in the next months a paper where we show that doxycycline reduces the need for rescue therapy after the surgery, improves the wound healing, gives a better result, especially in patients with nasal polyposis. And we also give, let's say, you have a surgical reboot, but also you can do, let's say, a medical reboot with a long treatment of methylprednisone. So we give 32 milligrams the first week, then we give for 2 weeks 60 milligram, and then for 3 weeks 8 milligram. The first month we do every week a local debridement to remove all the clots. We will also put in the DRAFIII neo-osteum a silicone sheet and maybe some grafting as well. We will see at the end of the procedure. And we then follow up our patients regularly with the 2, 6 months and 12 months visits to see how the neo-osteum of the DRAFIII is behaving. So now we will go to the surgery. Zo met op. Oeps, ik heb niks gedaan, hè? Tower plus navigation. Maar dat ding is weg, hè? Ah, daar. Dat is de cinema. Okay, 5. On the tower and on the navigation. Okay, good.
Als je nu de shaver met elektromagnetisch veld brengt, gaat hij automatisch connecteren.
Mogen ze op tafel leggen, de boer.
Gaan de schermen goed? Rien? Staat het gewoon goed voor jou?
Je moet zien dat je hem met. Allez, ja. Je mocht ook die leiding connecteren. Die leiding connecteren voor de shaver. Alright. Ja, hij moet ook voor de shaver erin. En in pomp 2. Oké. Mag de patiënt een klein beetje meer in anti-Trendelenburg? So, okay, so what is important is that you put the patient also in anti-Trendelenburg or reverse Trendelenburg. First of all, to have a good orientation of your skull base, but also this decreases the venous stasis in the head, so should reduce a little bit the blood loss during the surgery. So you see that we have a good decongestion, and so what you here see is this profound swelling of the nasal septum, which probably will be I think a respiratory epithelial adenomatoid hamartoma. So we will take some biopsies from that. And also you see here that there is pus coming out of the maxillary sinus. So we will take a swab from that to give maybe also postoperatively a directed antibiotic treatment based on this swab. So this will be probably a difficult area during our DRAFIII because we don't have a good view on the olfactory fossa, and also if there is still a middle turbinate left. I don't see a lot of turbinate anymore, so probably in the surgeries in the 70s or in the 80s they removed quite some normal tissue. We'll go to the other side to see. Also here we have this swelling. So normally we keep some polyps for laboratory examinations for the studies. So probably here we will be able to remove some of these polyps probably. Here you see a big polyp hanging into the nasopharynx. But also here it's very difficult to recognize any normal structures. So no middle turbinate, no superior turbinate. So here we will look for the maxillary sinus as well. Okay, can we have the swab? Okay. So here we see the opening to the maxillary sinus with very thick secretions in it and some polypoid changes. So we will start here on the left side by removing most of the polyposis, and then let's say at the end of the procedure we will do the DRAFIII or the Lothrop. So normally we would use you can use a shaver for this, but since we want to do research, we want to keep these polyps for a tissue biobank where we can do some research on this tissue. So this is quite gold for our lab. So probably the reason why this patient has no smile is because already a lot of the superior turbinate has already been removed, and also that this patient has a lot of mucosal inflammation in this area. And I think here we are already at ostium of the sphenoid sinus. So we use for the whole procedure a 30-degree endoscope. So now we are looking upwards. Okay. So this is a posterior ethmoid cavity. Can I have the Blakesley again? So here you see a polyp which is going into the sphenoid sinus. You see it over here. So the sphenoid sinus still has a nice opening. So this is okay. So we will now start using the shaver. So, and this is also good that we have a view on the sphenoid sinus, because this also gives us an idea if we don't have any, let's say, landmarks to see where the skull base, the height of the skull base is. So we know that the skull base is over here, so that here we will also have skull base, and then we can go quite in a safe way more anteriorly. Maybe this is still some small remnant of the superior turbinates. We will see in a minute when we remove the polyps surrounding it. Yeah, shaver. Okay. So normally you will see the shaver, the tip of the shaver is navigated. So you will exactly see where we are. So here we are in the sphenoid sinus. I'm touching the skull base. Here we are in the posterior ethmoid touching the skull base, so you see that it's very accurate today. So we will start removing some polyps over here. So first of all, I want to try to keep this structure, because maybe we think this is a part of the superior turbinate, and then we move more anteriorly, and we will take separate samples from this septal area. So here we are at the lamina papyracea. So to talk about a reboot procedure, so we have shown with a reboot that we have less recurrence compared to, let's say, a mucosa saving a procedure. Although there is some misconception that we strip all the mucosa, but which is, in my opinion, not true. So we remove, like you see over here, the mucosa with the shaver very nicely up to the level of the periosteum. So that's how we try to remove this mucosal inflammation. So this is quite easy to do, let's say, in the ethmoid cavity, but is more difficult in the frontal region and also in the maxillary region due to the anatomy. Oké, maak een keer een ronde circulaire punch. So what is important, especially for the postoperative care, is that we have a, let's call it a single sinus cavity, so where we have a large opening of all the sinuses so that topical therapies can have access So also here in the sphenoid sinus, we try to make the opening as maximal as possible. Okay, Bleaksley. So here we have still a small polyp. Yep. Okay. Alright. Goed, gebogen Bleaksley. So now we will take a biopsy here of this septal area and send this separately for our pathologist to be sure that this is a respiratory epithelial adenomatoid hamartoma. It's not that this changes a lot our, let's say, behavior, because we see that in most of the cases, when you are able to remove the inflammation in the sinonasal cavity, that this swelling will also disappear. Knippende Bleaksley. So it's quite, you also feel that this tissue has a, let's say, is more solid, harder compared to the, let's say, inflammatory polyps inside the nasal cavity. Oké, dus dat mag apart. So here we are now shaving on the septum to remove this swelling. So we like to use a 40-degree shaver, and you can see why, because with this 40-degree shaver you always work towards you. You can turn it, of course, but let's say when the opening is directed towards you, you always see what your shaver is doing, what it is touching. While with, let's say, a straight shaver, this is more difficult to see. Okay, we will put some cottonoids in. So you will still see also here some swelling. Okay, so now I think it's time to put some cottonoids with 1 in 2000 adrenaline. You can also use 1 in 1000 adrenaline, but we have good experience with the 1 in 2000, and so far we didn't have any systemic reactions to that with tachycardia or hypertension. And for the safety, you see that these pledgets are a little bit bluish, so we cannot mix up any local anesthesia with this high dose of adrenaline, so that we do not inject it. Okay. So we will now look to the maxillary sinus on this side. So here we have the inferior turbinate. We see that we already have a large opening, but a lot of edema, probably also with some thick secretions inside the sinuses. So here we try to be as, let's say, as aggressive as possible to remove all this edema. Of course, it's not always possible to remove all the inflammation, especially in the anterior part where we are behind the nasolacrimal duct. But here you see that we really don't strip the mucosa, so we just try to remove everything up to the level of the periosteum. It takes a little bit longer to heal, but we have done some studies where we looked at the quality of the tissue that is regrowing afterwards, and it's a functional tissue, so it has ciliary structures, it has tight junctions, everything, so it's not just a scar. Okay, Heuwieser. So we always check also whether the natural ostium has been connected. So here we have to be careful not to damage the infraorbital nerve. So this is also something you have to check on the CT, whether you have a dehiscent nerve or not. But in this patient, this was not the case. So this is a special instrument which we call the Heuwieser. It's a very curved instrument, and this gives you the possibility to, let's say, remove most of the inflammatory mucosa more anteriorly and more laterally. Okay. So if people are interested in this reboot procedure, we have a publication on that. It's in Laryngoscope from 2018, and the first author is Al-Sharif. Okay, the shaver. So when you use the shaver, we always keep the opening closed when we introduce or take it out of the nose. So that's a good feature of the Medtronic shaver, that you can program it that it's always closed when you move it in or out. So all right, good. Continueren. Nog eentje. Mogen wij nog continueren? Okay. All right. So we will go to the other side. So here again we see this big septal swelling. I think we have less polyps compared to the right side. We have a lot of, you see, thick secretions which are purulent from the maxillary. Let's see. What is a little bit atypical in this patient, if you look at the endotype of this patient, she has very low IgE. She has cilia, so you would expect if you see a picture like this that this would be a severe type 2 disease. So you see that here already we are again in the sphenoid sinus, and this is the posterior admit. So here you see on the navigation we are in the skull, at the skull base of the posterior admit. So it's really a polyposis which is let's say located centrally to the septum, which is quite atypical. So again here we will also remove all this inflamed mucosa. So here we are at the lamina papyracea. So you have to be careful. So we didn't saw in the CT scan any dehiscence, but we ask our residents or our colleagues to carefully watch also the eye. So if it starts to move, that we can stop immediately.
I have a question.
Yeah.
They ask, what is the curved instrument you are using?
So this is a 40-degree navigated shaver that we are using. So like I explained a few minutes ago, we like to use a 40-degree instead of a 0-degree because we can really monitor the opening of the shaver, so we see what is going inside. With a 0-degree you will have this kind of view, so it will be much more difficult. The other thing is with a 40-degree, if you use it in this direction, you work towards you, so you don't have the impression or the, let's say, the intention to push. Okay, so here we have a big polyp again, so we will keep this one for the lab. So in revision cases where you don't have, let's say, a lot of landmarks, I think the safest way to start is to start from the sphenoid sinus. There you have, like I said before, you have a good view on the skull base, and then you can come anteriorly. So can we have this circular punch? So also here we will open the sphenoid sinus maximally. Carison. And another instrument which I like to use is a 1 or 2 millimeter. This is a 1 millimeter 90-degree Carison, which gives you the possibility to do very, let's say, gentle work. Good. Okay. Spoelen. So here we are again at the lamina papyracea. You see that this is not really normal mucosa. So we remove this mucosa for this procedure up to the periosteum. This is something we would never do in a chronic sinusitis patients without polyps. But here we just want to remove all this inflammatory tissue. and then treat it afterwards with local and systemic steroids to, let's say, have both a surgical and also a medical reboot. So probably this is still a remnant of the superior turbinate here, so we will try to keep this small structure. Okay, can we have gebogen Blixley? So also from this side we will take a biopsy from this septal swelling. Mocht apart doen, sorry. Apart. Links en rechts apart, ja. So just to be sure that this is also RIA. Probably here we are going towards the frontal sinus, but we in fact do not want to touch the frontal recess when we do a DRAFIII, when we start with the procedure, so we wait really until the very last moment to look for the frontal recess, because what we will do is a outside in technique. I will explain you later on what is different in this technique from, let's say, how we were trained to do a DRAFIII a long time ago. So here you see this thick, very thick secretions. It's not really like, could be mucin, but so again also here we have to remove this swelling. So probably this will also, here we will do our septotomy for the DRAFIII. But you see this very, let's say, thick swelling of the nasal septum. So in most of the cases when you remove this mucosa, you will not have a septal perforation. And if you can then treat it with local and systemic corticosteroids, most of the time this will go away. The only thing that it's annoying that it makes our DRAFIII maybe a little bit more difficult, and also I think for this session a little bit less instructive, because we have this little bit of bleeding and abnormal mucosa at the septum. So of course when we have no middle turbinate, it's sometimes difficult to see where the olfactory fossa is. So probably here you will see that we start to arrive at the olfactory fossa. So there we have to stay a little bit more lateral, not to have any CSF leak there. So of course you have the middle turbinate in place. It's more easy to see your landmark over there. So I think this is one of the more extensive polypoid changes of the nasal septum I have ever seen. Okay, Kotsonovini. So this is what we mean with, let's say, a single sinus cavity, so that you have a good opening of the sphenoid sinus, you have a wide and complete opening of the ethmoid sinus, and then later on we will work on the frontal, and also that we maximally open the maxillary sinus to give a high volume and low to medium pressure saline rinses, which are also supplied with, we use or budesonide or mometazone in this lavage. And it's surprising how well you can treat your patients with this. I think there are still patients who will need biologicals, but I'm also convinced that a good surgery with a good local treatment with steroids can have very good results at this moment. Okay. All right. So now we will go to the maxillary sinus on this side. So the reason why we start also first with, let's say, the revision of the ethmoid and sphenoid sinus and then maxillary is that blood runs down. So if you first start with the frontal and then you go to the maxillary and then you go to the sphenoid sinus, the blood will always be obscuring your vision. So if you first start at the back and then you come anteriorly, you will have less of this visualization problem because of blood. So also here you see that we have this thick inflammatory mucosa. Spoelen. Hier de rechte knippende bleeksvlieg. So an area which is also sometimes a little bit overlooked in primary cases, it's what we call this area here. This is, let's say, the angle between the maxilla and the ethmoid sinus. So most of the time you will have a cell here where I'm pointing, so just behind the attachment of the middle turbinate and the posterior wall of the maxillary sinus in this area where there can be some inflammation left. So this is an area which we pay special attention to. So it's exactly this area here where we are working. Of course, when you, let's say, open the maxillary sinus completely, just so almost to the level of its posterior wall, you can have a little bit more bleeding of small branches of the sphenopalatine artery, but you can easily control this with a bipolar. So this is the, let's say, the angle between the middle, between the ethmoid and the maxillary sinus. Okay, the Heuwieser. So again, we will remove with the Heuwieser, let's say the more anterior inflammatory mucosa. We actually don't really strip all of the mucosa out, but we just remove as much as possible of the superficial inflammation. And our hypothesis is that from, let's say, the remnant cells in the periosteum, but also from the inferior turbinator is new mucosa growing inside this maxillary sinus. And okay, good. Continue. Good. So now we will start with all the steps for the DRAFIII, or what people call the endoscopic modified Lothrop. So you see that it's very difficult here to identify the frontal recess. You see some secretions coming out here. So I think if you would not do a DRAFIII in this patient, you will not be able to control the disease. And it has been shown by several studies that if you do a DRAFIII, you have less recurrence of the polyps. You have and you have a much better topical access of your local steroid treatment. So misschien de rechte knippende bleekslip. Rechte knippende, sorry. So you see here that we are almost going inside the frontal recess, but this is not, probably this is still a remnant of the middle turbinate here, which was lateralized. So, with the technique we will show, we really don't aim to open this frontal recess in the first place, but we want to go from the outside to the inside. And it's a technique which has been, let's say, popularized by the people from Sydney, by Richard Harvey. He has a very nice publication on that. The navigatie. So what is essential in this endoscopic outside-in technique is that you first identify your landmarks, and what are, let's say, the important landmarks. First of all, we will look for the most anterior parts. So here we are, it's a little bit far away. Right, we have to adapt the navigation a little bit. Yeah, So there is a question.
I have another question, but it's a bit longer question.
Hmm.
One of the participants asks, Dear doctor, do you agree that the success of treatment of such patients very depends how radically you remove all ethmoidal cells, especially posterior and close to the skull base? Because I see many quick recurrences, then surgeons leave a lot of ethmoidal cells avoiding complications.
Yeah. So I think so. Probably the people hear the question. I don't have to repeat the question. Bitul. So the people
Sorry?
hear the question.
Yeah, yeah, they hear
Okay,
me.
okay.
Yeah.
So I don't have to repeat the question. So I totally agree. So we have defined recently, 1 year ago, let's say the goals of the surgery and the completeness of the surgery. And what is we have defined what is a complete FESS, and it means that you, with a complete FESS, you have to remove all the partitions, the bony partitions within a single sinus cavity. So it means that if you have the ethmoid sinus, if it's anterior or posterior cavity, you have to remove all the bony partitions in this cavity. It means from, let's say, lateral from the orbit to the middle turbinate and in the skull base. So there in between you have to remove all the partitions and all mucosa and polyps. So it's what we often see in revision cases is that some of the cells have not been addressed, and I really think that the completeness of the surgery is an important step in, let's say, controlling the disease. On the other hand, we still have patients that despite complete surgery and maximal therapy need additional treatment who are not controlled. And I think these are the patients which are um, good candidates for biological treatment if they have, let's say, the right profile or the right endotype. So if we go back to the Lothrop, ja, daar juist staan, hij moet een beetje hoger staan. Ja, yeah, okay. So this is your frontal recess. So here we already see it. So, but then if you do a real outside-in approach, you don't see the frontal recess. And then you want to see what is your most anterior limit of the bone that you are drilling away. And if you look at the sagittal image, you see here this nasal beak. So you see that probably this will be the most anterior part of the bone that we will drill away. Secondly, we want to see where the skull base is. So if you don't have a view on the frontal recess, you really want to know where your olfactory fossa is starting. So therefore, we try to identify the first olfactory fiber, which will be your posterior limit. And then secondly, or thirdly, the lateral limit will be the frontal process of the maxilla, which we will drill laterally until we reach let's say, the periosteum of the skin, in fact. So if you have then identified the periosteum, the nasal beak, and the olfactory fossa, and you do it also on the other side, you really have a nice area where you can remove all the bone in between in a safe way. So, cotonoïden. Ja,
Ik heb nog een tweede vraag.
cotonoïden.
Somebody said it looks like a good sized maxilla from CT,
Mm-hmm.
but not intraoperatively. Don't you think?
Don't you think? Well, maybe we can check with the navigation. So here we are at the posterior wall of the maxillary sinus. So we look with a 30 degree. So we are really completely lateral. So I think we have, a very wide opening of this maxillary sinus. So I think we cannot, if we would open it more anteriorly, we will run into the lacrimal duct, which is really behind this structure here. If you look on the navigation, you can a little bit remove this still. And if you would go more down, then we will enter into the inferior turbinate. So, and here we have let's say, a view, in my opinion. So this is orbit, you see over here. So I think this is maximally opened. Yeah,
A third question, you were using an instrument, something like Heuwieser.
yeah.
Can you repeat the name and
It's
the instrument?
Heuwieser. It's a German name. I don't know where it stands for, but it's an instrument that is, I think, developed and distributed by Storz. And I can show you the Heuwieser. So you have and the andere ook. So I will show you, this is the instrument, how it looks like. So you see it's a very curved 90-degree, and you even have a more, let's say, curved one if you really want to go behind the lacrimal duct. So these are two, let's say, sizes of Heuwieser. Heu en dan Wieser. Oké. Zo, we gaan nog een keer kijken met de navigatie en dan de monopoleren. So, okay, so when we do this Lothrop, we will, so at the end probably we will also remove this, but I don't remove it now because when you will remove this, it will start to bleed and it will always be uh, making my endoscope dirty. So here we define the most anterior portion where we will raise a small flap to identify the first of the olfactory fiber. So in, let's say, in normal case, you will have quite normal mucosa over here, but here it's of course a little bit different because of all this inflammation at the septum. Okay. So this so we start with a monopolar, which we put on cutting, and then 12 on 12. So normally we have this middle turbinate which is in place, which will, let's say, give us a little bit of idea how far anterior and how low we should go with our septotomy. Here, this makes it a little bit more difficult. So here we go onto the bone of the frontal process, and then more laterally we will go down and anteriorly. And this is where we will make our septal window. And then we go, normally your landmark will be the middle turbinate, and you go up to the mid level of the middle turbinate um, and low and anteriorly you come with your septal window anteriorly from the middle turbinate. But here we don't have this landmark. So what we will do is to put the needle through the other side so that we have an idea where we have to be on the other side, so that we have a, let's say, a good symmetrical window. Okay, so now we will push down this flap with a Cottle elevator to look for the first olfactory fiber. Here, so most of the time you will find a small emissary vein in the first place, and then just behind that you will have this first olfactory fiber. So Probably this is this emissary vein here that we have. See here, which is situated always more, let's say, laterally. Hier de monopolaire. Huh? Monopolaire, monopolaire, mono. So we will coagulate this vein. Okay. So and then we will push this flap more posteriorly. So here it's a little bit more difficult to remove the flap, mucosa flap from the frontal process of the maxilla. So, and when we have identified our first olfactory fiber, which probably will be this one here, you see that this is a little bit more medial. We are at the level of our, let's say, olfactory fossa. So we will check with the navigation. So here we are in the frontal sinus here. It's our first olfactory fiber over here. So it's quite anterior, but we know that on this side we have a very small anterior posterior diameter. Okay, good. So we will. So you can keep this mucosa to make to make a flap. But as we know here in this case, this mucosa is so inflamed. I don't think this would be a good idea to cover your DRAFIII neo-ostium with this kind of mucosa. Okay, so normally we would have the middle turbinate here, then the mucosa of the septum, and so now we can go to the other side. So this is our posterior limit, this is our anterior limit, and here we will go for the lateral limit to the periosteum of this frontal process. So now we go to the other side. So I really like this outside-in approach because it's, in my opinion, it makes your surgery easier, also safer. So you have less problems with the bleeding and so. So here we have still a lot of inflammation, but this is the mucosa we will also remove. Okay, so the navigation. So again, here we will also look for our, let's say, anterior limits. We will start raising the flap. So probably this will be somewhere over here. Okay. So we make a small scratch with the navigation. So I think this is a very useful application of the navigation. And then we go with the Bovi or with the monopolar. We make a septal flap where we will go over this frontal process. So the other side, how we make the flap over the frontal process, and then we go anteriorly and go where we made our cut from the other side, which is actually here. So we can connect, and then we go posteriorly. Oké, een keer een cottonoïde. Misschien de frontale zuiger vanaf nu. Oké, is goed zo. You can use a cottle, or sometimes you can also use just your neuropathy to push the flap down, and like on the other side, we will still a lot of secretions here. We will look for the first olfactory fiber here. So it seems that there is still here some flap not really going through and through, monopolaire. Okay, cottle, mazing, sorry, mazing. So again, we will push this flap posteriorly. Normally we will find first this small vein and then more posteriorly. Cotton nog een keer. So actually what you see here is this frontal process of the maxilla. So this is the bone we will remove later on. Okay, so probably here we had this small hole. You see this is the emissary vein, and then so here we have this small sulcus, which is the emissary vein, and then more posteriorly here you will see the first olfactory fiber, which is actually over here, so in this area. So this also means that here we have this nice landmark that all this bone here in between and to the lateral we can remove safely. Shaver. So now we will shaver away this. Okay, and so here we see this very thick bone. So here we are at the nasal septum. We have this very thick bone that we have to remove to create the septal window. So the size of the septal window is just, let's say, small enough or big enough to allow you to work from one side to the other. So that's really the rationale of this septal window. Yeah, Garrison. So probably we will also have to drill this septal window. I will try to go in between with my Garrison. Alright, Blixley. Ja, in zaal in zaal 8. Ja, ça va. We hebben hier ook niet zo heel lang meer werk. Hm? Wat blieft? Ja, ja, ja. Maar we hebben hier niet zo lang werken. Okay, so we will have to drill this away. So normally this bone is quite thin and can easily be fractured. So we will now switch to our drill. So what we use is a 70-degree diamond drill. Mocht de irrigatie op 30 zetten. Can you put the irrigation on 30? Oh, wacht. Yeah. So, yeah, okay. So the settings that we use is that this is a 30-degree, a 30K diamond burr, which has irrigation and also suction on it. You could also use a primen. Kun ik water primen? Dat we water hebben. And we also use prime, lots of irrigation on it. So So normally we don't have to drill this this septal bone, but as you see on the CT scan, this bone is very, very thick in this patient. So you could also use a 15-degree burr, I think, but I think it's best to use diamond drills with a high speed. So I think the development of 30K burrs have really been a major advantage for doing this kind of surgery. Okay, so now we have a nice view. So we have here the frontal recess of the left side. We have the frontal recess of the other side. We have first olfactory fiber on the right side, first olfactory fiber on the left side. So it means that the bone, which is from this side to this side, can safely be removed. And here we will look for our lateral limit, which will be the periosteum of the skin, in fact. So, goed, boren. Ja, misschien. Ja. Misschien moet Christine even gaan en dan jij later. So, how we do it is that we try to make some circular movements. Really. Kan de irrigatie nog wat hoger? So we will ask for a little bit more irrigation. Nog hoger als kan, ja.
50 cc?
Ja, is goed. So and what we are looking for, een beetje flushen, is this blue coloring. Okay, and then here we start to see. So I think here you start to see already a little bit of the blue coloring, but you have to remove more. Okay. Okay. So here you see that we are, let's say, at the level of the skin. You see, my colic is pressure. So this is the most lateral limit, and then you see this, let's say, quite triangular bone, which is really obstructing our vision to the frontal recess. So this we also have to drill away later on. So Then we will continue to the other side. So we will do the same on the left side. Spoelen. Is verstopt. Hier een dikke zuiger. Ja.
We have a question. They ask if this drill has a suction.
Yeah. So this drill has a suction, but it was blocked. So now we unblocked it. So you see that here in the center, right? Can you see it? This is a small opening of the drill, so you can suction your lavage fluids, but from time to time this can get obstructed as well. So probably here we will have a little bit less bone to drill away. Yeah, okay. So also on this side, spoelen. We have identified here our, let's say, our lateral limit. Okay, so now we can start removing the bone, let's say, in the middle. And it means that we just go from side to side, so we can start removing this, let's say, what is described as a triangle of bone, which is so what Wormold is also removing with his axillary approach, or what the people from Sydney are describing as Caroline's window. So you really have to remove this triangle of bone to have a good view on the frontal recess and on your DRAFIII. So now we can start drilling here in the middle. So we know that we are safe because this is our most posterior limit, and we try not to just press and make a hole. So we try to go from side to side to thin this bone, and then maybe later on open it with a with a Carrison or frontal rongeur. Luister. Ja, die bulken. Ah, 3 kwartier. Hè. So now we start removing this frontal beak. So we know that we have quite a large one in this patient. Okay. So and by doing this inside out technique, I think you remove much more bone compared to do a regular inside out approach. Is verstopt de zeuger. So there was, you see a little bit the blue shining of the frontal sinus. So we will not be, let's say, tempted to push through and through it, but we will remove more bone and try to enter the frontal sinus as late as possible, not to have any more bleeding in our field. Okay, the frontale zeuger. You see we are going in the, but we are here already in the right frontal sinus, so we will now remove more bone here on the other side. Okay. here. Yeah.
I have two questions.
Yeah.
First question is, do you need more than one drill to do the procedure? The second question, do you only use diamond drills or diamond burrs? And on what speed do you use them? And the
So
third question just came in, is it possible to track the burr?
is it possible to?
Track, so to navigate.
Ah, I don't think it's possible to track the burst so far as I know. So,
And I can
but
confirm it's not possible.
so the burr we are using is a 30K burr. So, and what was the first question?
Do you need more than
More
one
than
burr?
one drill. Well, it depends. It's a good question. So it really depends from patient to patient. Yeah, the amount of drilling. So I would expect here in this case that we would need two drills. It's not that the drills are breaking, but sometimes they get clogged and we cannot, let's say, remove all the clogs anymore. I think in the past when we had this 12K drills, they had a tendency sometimes to fracture, but now I think with the 30K bursts this is rarely the case. Yeah, it really depends on sometimes we need two drills. So especially when you start pulling on the drill, so when you start to do this kind of pulling towards you, I think you can damage your drill. So if you take a little bit of patience to let the drill do his work, this pull.
So one of the questions also was, do you only use diamond
Yeah,
burrs?
so I only use diamond burrs. You can use cutting drills as well, I think, but it's just yeah, a matter of preference. So but you have a lot of people who are only using diamond drills. So what I want to show you here is that we have this opening we drilled, and in fact here you have the frontal recess. So it's really at the end of the surgery. So if I would put my instrument in it, so you see that this is a frontal recess, and normally at the end of the procedure we will connect those two. So you really go from, let's say, not from the frontal recess into the frontal sinus, but from, let's say, the outside. So that's how this technique is called, outside in. So we really have to remove more bone so that we can see the anterior wall. So here we already have a good view, but we have a very thick interfrontal sinus septum, and we would like to, we call it squaring off, so that we have a very rectangular angle, and that we also could see the roof of the orbit in a better way. So on the right side it's already quite okay. On the left side I think we need some additional drilling, but of course this was also, let's say, the smallest frontal sinus we had. So spoelen. So this is what we call with the squaring. So we will remove more, a little bit more bone laterally, so that we get a nice view on the roof of the orbit. So we know that here we have the skin, and here we have the level of the lamina papyracea. So you see that there is still a little bit of bone overhanging this frontal sinus that we have to remove. All right. So here we have a nice view on this anterior wall of the frontal sinus. You see that it's more in one line, and here we are looking really above. You see there, you see the roof of the orbit. So we will do the same on the other side, and I think then we are, let's say, with the DRAFIII, remove a little bit of blood here. Okay, so pull him. Okay, so let's have a look. Okay, so he's pulling. We still need to remove a little bit of this bone over here, I think, so that you have a good view on the superior part of the orbit. I think on the other side we already have achieved our goals. Moet al zo'n siliconen sheet vragen. Ja. So we also will remove a little bit of this posterior bone here, very gentle, but this gives a little bit more, let's say, space to drill over here. So here we also want to go make this a very nice squared angle, and to Yeah.
I have a question. The question is, would you suggest such an operation for a first-time patient undergoing surgery if you see such massive polyposis?
No. So I think our strategy, or let's say our algorithm, is that DRAFIII to control polyposis is not, let's say, something you do at the first surgery. You can discuss, I think, about reboot. Maybe we should, I think, provide the medical community with a little bit more, let's say, evidence about that. Mocht de shaver het terug installeren. But I think it's a stepwise approach or a ladder approach that you do a complete sinus surgery without DRAFIII in the first as a first surgery. And I think if the polyps recur and the patient has headaches and a lot of symptoms, I think a DRAFIII to control the disease is, I think, is a good option.
I have another question. The question is, do you change scopes during the procedure or do you use the same angle
Now,
throughout?
we have been using the 30-degree throughout the whole procedure now. So you have people who do, let's say, only a 0-degree. You can perfectly do that. So, but we try to keep the things as simple as possible. So we only use a, let's say, a 30-degree through the whole procedure. Sometimes when it's we can switch even to a 70-degree if necessary. So what I'm doing now is I connected the frontal recess, which was affected here, with the neo-ostium of our DRAFIII, and I am removing some of, let's say, the remaining polypoid disease or inflammatory disease in this frontal recess. So this is now more or less cleaning up of the field. So you can have some bleeding over here, so that's why at the end of the surgery we will remove, we will coagulate a little bit, and still we have this, let's say, polyp, oops, this swelling over here, which we will also remove because we think that's, but as I said before, I didn't do that in the beginning of the surgery because normally this can bleed and will make your endoscope dirty all the time. So the good thing about this debrider is that if necessary you can also pull it or turn it backwards. So, but of course then you lose a little bit of your control. But here I think it's not a problem. So normally at the end of this procedure you will have some kind of, we call it a T. So where you have the, let's say, the septum, you have an arm like that, and then you have the middle turbinate. So here it's of course a little bit different due to the absence of the middle turbinate. Mocht de volgende vragen. Hè? So we are just cleaning up a little bit now, but I think we are almost finished. So what we will do now is that we put a small silicone sheet inside this new ostium to guide a little bit the healing. And so maybe we will check with the navigation our boundaries of the DRAFIII. Yeah.
I have a question. Somebody asks, is it possible to keep the mucosa flap intact to place over the bone at the end?
Yeah. So I think I already answered that question during the surgery. You can keep this mucosal flap if you want, and you can put it or backwards or covering this bone. But of course, let's say in this patients, we don't like to do it because this mucosa was also diseased. But there are some nice publications from the group of Castelnuovo, Alcatani, who have shown some flaps. We also had some experience with posterior base flaps, so I think it works. Probably I will put here some small free mucosal graft on. So just to have a look, so here we are really, yeah, as you see that the navigation is a little bit less accurate, but you see that really we are really very anterior. So here, so I think the navigation is not correct anymore, but here you see we are at the lateral limit of the frontal sinus. Here we are, let's say, at the posterior limit. So I think we have a maximal opening. So the sheet we are now putting in is a how thick is it? A 0.5 millimeter, I think, silicone sheet also from Medtronic. We cut it in such a way that it will cover both the bare bone and the frontal sinus, but also at the superior part um, of the frontal process, which we drilled quite extensively.
We have a couple of questions.
Yeah.
One of them is, how do you know when to stop drilling on the T to avoid going through?
You mean that we go through the skull base and we have a CSF leak? I think your landmark is the first olfactory fiber, of course. So that's let's say your landmark that you don't have to drill posterior from it. So that's why I think this technique is so good that you really identify first your landmark, that you cannot um, have a coincidental entrance of the skull base during the surgery. Oops.
Another question, does flap reduce the crust after the surgery?
Thus,
Flap,
what?
the flop.
The
Of,
flap.
yeah.
Yeah. I think it's both. So we have our silicone sheet. I really like this. We have been doing this now for, let's say, 1 or 2 years. Um, we'll put a small mucosal graft here from the inferior turbinate. Um, I'm not really, let's say, for me, the crusting, I think at the end it will go away. It's a closure of the neo-ostium that you can have in about 20% of the cases. I think we still need some good studies to show. I think that the flaps really reduce the number of closures. So what we will do now is to take a small mucosal graft from this inferior posterior part of the inferior turbinate, and you see we are not even inside the bone.
I have a
Okay,
question
Blixley.
about this. The question was, do you cover parts of the bone of the DRAFIII axis with mucosa from the lower turbinate?
Well, actually, I'm doing this right now.
Yeah.
So we will take. So this is a small. Oops. Okay, if you see it, a small free graft. So we will thin this a little bit out, um, and probably take another one on the other side. So we also know from, let's say, studies that this mucosa of the inferior turbinate is different than mucosa from, let's say, the superior or the middle turbinate, and it has less. You really don't see almost no polypoid changes of this inferior turbinate in a case with nasal polyposis. So, yeah,
They ask if you can please show the shape of the silicone sheet
I will show
before
it. I will show it. Yeah,
insert.
yeah. Hele dikke zeur.
Another question. Can you still embark on this operation if you have no navigation?
In fact, in my opinion, you can. So if you have really no navigation, um, you by identifying your anatomical landmarks like this, the first olfactory fiber, and then staying anterior to it, and by identifying the skin laterally, in fact, you really don't need navigation as such. So of course, for this, so we have the availability of navigation, of course, so we use it also for, let's say, for our residents to follow the surgery, but I think it's really not mandatory to do. So here you see that this bulky posterior part of this inferior turbinate, we take this small flap, basically. Okay. Good. So then where is the silicone sheet? Okay. So the silicone sheet is not always easy to see, but has a, let's say, has a big T, which, will be in the frontal sinus. So this superior part will be in the frontal sinus. This part will be, in fact, at, let's say, the nasal dorsum, and then it will fold like that and cover the frontal process of the maxilla over there. It's, for me, the most difficult part of the surgery to put it in, but it takes some time to maneuver it in and to be sure that it's in the right position. And we keep this in for about 4 to 6 weeks.
Okay.
So we will first put this silicone sheet in place, and then we will place the grafting between the silicone sheet and the bone. So here we are putting this T inside the frontal sinus over here, also on the other side, and then we have to pull this leg through your septal perforation to the other side. And if you now push it superiorly, should be quite. And of course, we will put some, let's say, extra support to it with a small amount of gel foam. Okay. Ja,
Want
moeten we
participants
gel
ask
foam hebben?
if you have empty nose syndrome with this surgical procedure?
Hmm. Well, in fact, I think the empty nose syndrome is still something very questionable. Um, I do believe that some people really are suffering from this kind of disease. On the other hand, we see that with quite extensive tumor surgery, we we don't have this. Oops, I lost my graft. Blixley. We don't have this really symptoms of empty nose. So I don't believe that an empty nose can appear after a DRAFIII, because you still have a large part of the septum, you still have your inferior turbinate in place. So I don't think that this can be attributed to a DRAFIII procedure. So Rejalfo. Okay, so now we try to, oops, no. So to put these grafts really here at the area of the bare bone, and then get a frontale curette.
Een andere vraag die we hebben. So I have another question.
Mhm.
How do you do post-operative care? Do you use lidocaine spray only?
Um, to clean, so it means to lidocaine spray to do a local anesthesia. Yeah, we use only pantocaine spray and adrenaline to decongest. So here you see that the first graph is already in place, and now we will put another one, which we lost again, Blixley. So we will do this, let's say, debridement weekly under local anesthesia in the outpatient clinic with pantocaine spray and adrenaline. And okay, it's not, I think, the most pleasant procedure for a patient. Some people say that it's more demanding from them than the surgery itself, but you see, so that we are covering all this bare bone on the frontal process. Okay, good. So now we will put this back on, and we have the gel foam, 3 grote stukken gel foam. Gel foam, not gel foam. Gel foam. So we will put now, mocht er 2 of 3 geven. Is dat een groot? Nee, een kleintje. Okay. Yeah. So we will put some spongostan or gel foam inside the opening to keep both the graft and the silicone sheet in place. Nog eentje. Had er 2 of 3 gevraagd. Oh. So you see that with this film, all the bare bone is covered, and I think in a few days it will really stick to it. And we remove it on the outpatient clinic after 4 to 6 weeks. It poses no problem to the patients. It's really soft to remove. Yeah. Yeah.
I have a question. What is the most common indication you face for DRAFIII procedure?
It depends a little bit on your the area where you're working on. I think you have indications first of all to control polyposis. Here in Ghent, I think this is now more and more becoming the most common indication. On the other hand, you have to do sometimes DRAFIII surgery for tumors of, let's say, medially situated osteomas of the frontal sinus. And then you have, let's say, patients who already had multiple frontal sinus surgeries for chronic sinusitis without polyposis. They can also have an indication for a DRAFIII. So I think when I started here, ja, nog niet, nee, dat is goed. 2 kleine merelcells en 2 grote merelcells. I think we did maybe 10 or 20 draft threes a year. I think over the past 5 years, this number has, let's say, almost tripled. And it's, in my opinion, due to the fact, to the knowledge that we have, that it's better to control polyposis so that you have better access with your local treatment. And also with, let's say, how familiarized we are becoming with this outside in technique, which is, in my opinion, safer, easier, and faster to perform. I think our threshold for a draft three is really lowering, and it's really a safe procedure. So if you find this olfactory fiber, the chance that you will enter the anterior cranial fossa is very low, and also the number of other complications are, let's say, extremely low. So even patients tell us that their smell has improved significantly even after a draft three. So I think this is, in my opinion, the indications are multiple for draft three.
Another question, do you think oral steroids are beneficial to surgery if given preoperatively?
Hmm.
And do they help post-op?
Well, there is still some debate on that, whether it's beneficial. So there are some studies that show that it reduces the, let's say, the blood loss, and it improves the surgical field of the surgeon. On the other hand, we let's say, give a lot of steroids post-operatively to our patients to have this, let's say, medical reboot. And if you give your steroids pre-operatively, I think you will have, let's say, a false negative mucosa. So you will see that your mucosa looks quite okay because of the steroids, oral steroids, and I think you will remove not as many mucosa as you inflammatory mucosa as you would remove when you will do it without this steroid. So um, we actually don't give this steroids pre-operatively. The third reason, it's our reason for science, of course, that if you give steroids preoperatively, then of course all your examinations for, let's say, endotyping and looking at the inflammation inside the polyps will be distorted. So that's the reason why, multiple reasons why we don't give steroids preoperatively. Okay, de grote middelcel. So so if you have questions, no questions,
Yet.
everybody. So
Dear Professor Vanzella, this is Julia. Yeah, I
hello,
think we
Julia.
are, yes, we are done with the questions. I don't see any questions, and
Okay,
participants are sending the messages thanking you very much for these demonstrations. They were very helpful, and they were glad to join, and they are
okay,
very much looking for more.
okay. So do they hear me or no? Not now. Yeah.
Yes, they do.
Okay,
Actually,
okay.
I have just one last question. Do you mind if I read it
Yeah, yeah, of
quickly?
course.
I have a
Laat
patient
voorlezen.
with severe frontal disease that has breached the orbit and will require a draft 3. They also
Mm-hmm.
have Panson's disease. Would you
Mm-hmm.
advise staging this procedure?
Um, it depends, of course. So I think probably what I can imagine is that these patients will have some kind of frontoethmoidal mucocele in the supraorbital recess. I would not stage this procedure, but what I would do is a draft 3 combined with an orbital transposition. So it means that you do a maximal draft 3, and then you remove, let's say, the superior bony part of the orbit, so you can really have lateral access to this probably mucocele which has breached the border between frontal or at supraorbital region to the orbit. So I would not stage this into, let's say, a FESS and a DRAFIII. I would do this immediately at the same moment.
Great. Thank you. And I have another question. So how long do you keep the celastic sheet in place?
We keep it in place for 4 to 6 weeks. So it depends a little bit at what time we see the patient, how the things are let's say, evolving. But I think the latest point to take it out is at 6 weeks.
Perfect.
And then
Thank you.
most of the healing has been done, and I think you can expect that all the bone has been resurfaced with new mucosa.
Okay,
Okay,
great. So no more questions.
no more questions. So
I think we can
bye
close the
everybody.
session. Thank you
And
very much,
maybe
Professor.
in the future we will do another case. Okay, bye bye. Thank you.
Absolutely. Bye. Thank you.